Silent, keep it silent. Okay.
Yes, sir, we are live. We can start.
Good evening, everybody. Today we are doing a live session about examination of thyroid. We had similar live sessions earlier. There's a big gap over 3 weeks because of some other reason. I welcome for this session. Now all of you know that because Professor Robinson George has joined many several locations earlier from Pushpagiri Medical College, Tiruvalla, and welcome you, Robin. And I also welcome Professor Manoharan sir might join us again, which he was there earlier sessions also from Puducherry Vinayaka Medical College. Puducherry, professor and SHOD he was, but senior faculty. And I welcome all students who are joining for the sessions and also faculties either through Google or YouTube. And of course, I welcome today's presenter from Pushpagiri Medical College, final MBA student, Ms. Linsa Vijay. She is presenting on examination of the thyroid. Request every students to join this one. Have live session how exactly you examine. It's very very important for exam point and how exactly you present the case, how exactly go out. It's a very vast subject. It will very, very useful for all final years, of course, postgraduates also. So the basic thing how to examine, go ahead with the management of thyroid and examination of thyroid. So with this brief introduction, we'll straight away without wasting time, go ahead with the presentation by Mr. Linsa Vijay. And Shreya, start the PPT presentation. Request Linsa Vijay to start the presentation straight away. Thank you very much.
Uh, Good evening, everyone. Today I will be presenting on the thyroid's examination. Please, can you put the next slide? So presenting the case of Miss X, who is a female patient of age 50 years. She is a homemaker by occupation, residing in Idiki from Kerala. She is from middle class socioeconomic status according to modified Kupuswamy scale. She was admitted to the ward on 5th of November 2024 and she was examined on 6th of November 2024. Can you put the next slide? Yeah. The chief complaints are swelling in front of the neck for the past 2 years and discomfort while swallowing for the past 6 months. The history of presenting illness is as follows. The patient was asymptomatic 2 years back. Later, she noticed a swelling in front of her neck. Initially, the swelling was small in size, which was about 1 finger breadth measured vertically. Over the course of the past 2 years, it has gradually increased to a size of about 3 finger breadths measured vertically. Patient also gives a history of discomfort while swallowing since the past 6 months. It was gradual at onset, progressive in nature. It is more noticeable when swallowing solid food. It is not associated with coughing, choking, or regurgitation of food. There is no history of pain, no history of heat or cold intolerance, no history of dyspnea or hoarseness of voice. There's no history of loss of appetite, anxiety, irritability, palpitation, insomnia, or tremor of hands. There's no history of protrusion of eyes. There's no history of unexplained weight loss. There are no other swellings present on the neck or anywhere on the body. The past history is as follows. There are no similar episodes in the past. There is no history of irradiation to the head and neck region. Patient is a diabetic since the past 10 years and is on oral hypoglycemic agents, which is as follows: tab, glimepiride 2 milligram, and tab metformin 50 milligram. There's no history of hypertension, asthma, or tuberculosis. There's no surgical history in the past. The personal history. Patient consumes a mixed diet. She has normal appetite. She has adequate sleep. Her bowel and bladder habits are normal, and there are no reported allergies. The menstrual history is as follows. Patient attained menarche at 14 years of age. The menstrual cycles were in regular duration of 28 days, which lasted for a period of 5 days. And patient attained menopause at 49 years of age. The family history shows that the patient's mother has a history of goiter. These are the pictures for inspection. The general examination. Patient is conscious and cooperative. She is moderately built and nourished.
Linsa,
So,
wait. We'll have a
Yes.
small discussion about the history, Robin.
Yes.
Go back to the first slide. Okay, next, this chief complaints, when you say next slide, when you say chief, only discomfort, and what's only discomfort while swallowing, or something else is there? Because there's a discomfort, hoarseness of voice, or anything specification is there?
Sir, I asked her and she only said there was discomfort while swallowing. There was no hoarseness of voice or
No
dyspnea.
breathing difficulty or anything?
Sorry, sir?
No breathing difficulty, dyspnea or anything?
No, sir. She didn't report anything like that.
Next slide. Okay. Okay, you said asymptomatic 2 years and eventually swelling. Whether there's a rapid history of increase in the swelling?
No, sir. This was a gradual increase in swelling over the past 2 years.
Okay, it's only you said difficulty in swallowing for a solid food, not
Yes, sir.
for liquid. And
No,
you
sir.
said coughing, choking, regurgitation is not there. Why coughing? Why you are interested in asking that question?
Sir, if there's a obstruction to the trachea while she's swallowing food, it would result in cough.
Trachea?
It-
Okay, question for trachea. Okay, okay, it is not there. You said it's not there.
No, sir, it's not there.
Okay, next slide, Shreya. You said okay, you said with thyroid functional status. You mentioned everything in detail. Why you have mentioned the protrusion of the eyes?
Sir, I was checking for any signs of hyperthyroidism.
Okay, hyperthyroid. Unexplained weight loss. In which condition it is quite common?
Sir, unexplained weight loss can be due to hyperthyroidism
Yes,
or
mainly in the primary thyrotoxicosis.
that's
Why
it.
pain you have mentioned? Why you are interested in asking the pain?
Sir, if there is any case of thyroiditis, we want to rule that out.
Okay, only thyroiditis will cause the pain.
Sir, any hemorrhage into the swelling?
Okay. Any other reasons to have a pain?
Um, I think these are the reasons, sir.
Okay, malignancy with the rapid increase in the size in malignancy also it can cause pain, especially
Yes.
when it infiltrates 4A,
Yes.
4B types. Okay. Why you ask for no other swelling in the neck? What's the reason behind in asking that?
So mostly we are concerned about lymph node swellings in the
Okay.
neck.
Okay. Why you wanted to ask about the anywhere in the body swellings?
Sir, any bony metastasis, for example, in follicular carcinoma,
Okay. It can cause swelling where?
in the flat bones, like the skull.
Okay, skull and other.
Yes.
Okay. Okay. Next, why loss of appetite and what is the cause for loss of appetite and all those things? Hyperthyroid you have mentioned.
Yes.
Voice, what is the cause for hoarseness of voice you want to ask?
The hoarseness of voice due to infiltration to the recurrent laryngeal nerve.
Okay. Okay. Next slide, Shreya. Possibly you asked in detail. Have you asked any irradiation? You have mentioned about that.
Yes.
Hypertension, asthma, any treatment she's taking about in relation to thyroid? Have
No,
you
sir,
asked,
she hasn't taken anything else.
like which thyroid, which treatment drugs you are interested? If you want to ask about the in relation to thyroid swelling.
So any goitrogenic drugs?
Okay, drugs. Okay, right. Agreed. Any other thing? Maybe thyroxine itself. Maybe patient
Yes.
taking thyroxine itself, or maybe patient taking antithyroid drugs also. If that's an
Yes.
option, so those things also had to add on to that. Goitrogenic drugs should be asked for. Absolutely right. No surgical history in the past. Why you wanted to ask no surgical history in the past?
So if there has been a prior hemithyroidectomy surgery that has been done, in
Okay.
case of if we have to do a completion surgery,
What is the meaning of there are no similar episodes in the past? What is that similar episodes? Swallowing episode, you are discomfort in the swallowing episode or anything else?
so swellings in the neck, front of the neck.
Okay, earlier before appearing this swelling, or there is any reason why? What is the meaning of similar episodes? You have mentioned that in that. Swelling
Sir,
or discomfort
sir,
following.
so both discomfort while swallowing is if there has been a past history like that,
Okay,
and
okay. Next slide to Shreya. So consume diet, appetite, adequate sleep, bowel. Why sleep is important?
the sleep is disturbed in the case of hyperthyroidism. Patient is nervous and irritable, so they have less sleep. And in hypothyroidism, patient is more tired, so they will be
Okay.
tired.
So in short, when you take history, swelling, duration, progression, and pressure symptoms history, and functional status, whether it is euthyroid, whether patient is hyperthyroid, and if you are thinking about the malignancy, it's a progression and it's relevant to that. So whatever
Yes.
that required, so specifically you asked for. So Robin, over to you. Anything else extra in detail you can also discuss history.
Just to add on to what Sarah said, Linsa, from history of present illness, site of the swelling, the onset, you have said since 2 years there's nothing, and just exactly like what Sir pointed out, suddenly the swelling will not come. So
Yes.
initially it was something, and gradually over a period of time, over a period of 2 years, it has developed. Yes,
Yes.
the idea is evolution of the thyroid swelling. So differential diagnosis, when it comes, we're talking about some sort of goiter maybe or malignancy, right?
Yes.
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 So then the character of the swelling, as in from where to where, is it from one side to one side? How much has it extended?
Okay. Sir.
Again, the same thing, evolution of goiter.
Yes.
Uske baad, the next thing is the associated swelling that the complaint you've said is difficulty in swallowing. Yes,
Yes.
quantity and quality of it.
Mm.
Exactly, causes of dysphagia.
Yes.
What was the problem? Was it initially two solids to liquids, and how long did it take for this thing to develop?
Mm.
And you have covered, just for the sake of revision for the other students, I put up in the YouTube also. You covered everything from congenital lesions to inflammatory, which you have covered. No history of pain.
Yes.
Thyroiditis. Sir has asked you what are the differential diagnosis.
Yes.
Thyroiditis is a benign problem. You have a malignant problem also. It's painless to start with, then becomes painful with
Painful.
infiltration,
Yes.
right? Yeah.
Yes.
Then you have the other things like inflammatory is over, the benign swellings. You have goiters, you have colloid or diffuse goiter, nodular goiters, and multinodular goiters. Then you have malignant swellings. The malignant swellings, all the metastatic, the changes that you see in malignancy, you added loss of weight, things like that. Okay.
Yes.
In the past history, you added something, Sir has again pointed out, no similar episodes in the past. That is not significant here, as in Sir has specifically asked, what episode? The
Yes.
swelling will not come and go.
Mm.
And dysphagia. If that is your point, then you have already made it clear there.
Yes.
Past history is mainly about surgical history, medical history. That's it.
Yes.
Okay. So surgical history, you said something about hemithyroidectomy. So if at all an examiner asks you, the
Yes.
surgery was done how many years back, and how long does it take for the patient to develop a new swelling?
Mm.
So be very careful with these sort of things. Okay.
Yes.
And nowadays, hemithyroidectomy is very rare. We always
Mm.
go for total thyroidectomy, most of our Indian patients, right?
Yes.
Then the next thing that you did in past is medical history, matlab whatever drugs that you're giving. So basically, goitrogens. You
Yes.
have dietary sort of goitrogens, and the classification of drugs that can cause goitrogens. Can you give us a few classification group of drugs that can cause goitrogens
Sir,
other than thyroxine?
Yes, sir. Amiodarone, which is an anti-arrhythmic drug.
So you have anti-arrhythmic drugs. So one thing. Second,
The antipsychiatric drug, lithium.
antipsychotics, lithium.
Yes, yes,
Yeah.
sir.
Anything else?
Then para-aminosalicylic acid for
Yeah. So you
anti-tubercular.
have anti-TB drugs. Very good. Yes. So there are three things which are very commonly used now. The first two are very important because you have a patient who presents to you with no swelling, but with symptoms of something,
Mm.
thyrotoxicosis.
Yes,
And
sir.
you have referred the case to your colleague in cardiology or to psychiatry, and they have started the medicines on these things, lithium or amidon, and hence, okay, very good. So the main chain in that is the iodine thing. Very good. Yes. So
Yes.
goitrogens, just make sure you know all the goitrogenic drugs that cause this
Yes.
problem. After that, you have covered past history. Yeah, you have covered all those things. Personal history, mixer diet, normal appetite. Now, this is a patient, so try to make it interesting, as in normal appetite. Yeah, adequate
Yes.
sleep, quantify it, because it's very important when it comes to a case of thyrotoxicosis.
Yes.
Lack of sleep is very important.
Yes.
So the pattern is disturbed. Bowel and bladder habits, again, quantified if possible. No reported allergies. Okay, it's not very significant, but okay. Family history.
So mother has a history of goiter.
So it usually runs in the family. Most of these
Yes.
things, carcinomas, goiters, especially all these things run in the family. Endemic goiters, commonly seen in
So areas of low iodine.
Yeah, so mountainous areas and flat areas with low iodine.
Flatlands.
Seafood
Yes.
with low iodine. Yes, very good. Okay, so you have covered basically everything in history.
So,
One small question I just want to know. You wrote something in past history. No, patient does not give history of irradiation to neck. Why
Yes.
did you ask that?
So any childhood malignancy like lymphomas?
Like
Uh,
like lymphoma.
yes, sir.
Oh,
Uh,
then
uh, sir, any yes, sir. So irradiation to due to any malignancies like that? If
so you have a benign problem. It's a very old thing. I'm sure you know of this.
yes,
It's not there in the textbooks. Only in very very old textbooks it will be written there. You're
yes,
right about lymphoma, but you're not very specific. Why lymphoma?
yes.
Why did you?
which
Nowadays we don't see this.
which lymphoma
Why?
irradiation are given in childhood? Which lymphoma is common? NHL or HL?
Sir, NHL.
NHL is common in childhood, which has got a very good
Non-Hodgkin's.
presentation.
Oh.
So yeah, Hodgkin's lymphoma is more common.
Like you just,
So
yeah, you may have to
what
find
was the,
common.
what was the reason why these children had this problem? Why
Uh,
why neck?
Sir,
Which
I'm
is
not
not seen
sure.
nowadays.
Yeah.
Yeah, there's something called the shield technique. I'm sure when you read Hodgkin's lymphoma, you'll know. They used
Yes.
to irradiate. So if there are other portions, this portion was not shielded.
Hmm.
So they were exposed to this also. Now that's a malignant condition. You're absolutely right. Can you give one
Yes.
benign condition for which now it's not seen because it's not very common? It used to be done before.
Um,
There was neck irradiation, and they found out these sort of let's say papillary carcinomas. Any
so for
benign condition?
solitary thyroid nodules,
No, children, childhood, solitary, not very common.
sorry, I'm not sure, sir.
No, earlier they were giving radiation for acne, hemangiomas, even
Yes.
tonsil, adenomas, all those things.
Ton-
Yeah,
And so,
Tonsillitis, acute condition, they're
tonsillitis, they
very
used to
common in
give
childhood.
radiation.
focus.
Of course,
They
not
used to
now.
take X-rays. Yeah, they used to take on X-rays to the neck, irradiation
Focus.
to the neck, and these children used to develop.
Taking X-ray.
Okay,
Focus.
very good. Yeah.
Repeated
Okay.
X-rays in the neck, that's why they get exposed. Okay,
Focus.
right.
Yes.
Sorry, Robin. One question because he
Yes,
said
sir.
mother had the thyroid disease. Whether she was operated, whether in treatment done to her, or it was left like that. Have you asked that detailed history?
Yes, sir. There was no information because she wasn't really sure whether it was surgically resected or not.
Okay, she was
So,
not knowing it.
yes,
Okay,
sir.
okay. So we'll go to
Okay.
next, Robin. Is it okay?
Yes, sir. She has covered all the features. Yes, sir. Yes.
Covered all that. So whatever Robin had discussed, very important. Why irradiation? You should be able to give an answer. That's what he meant actually.
Yes.
Whatever you are written, whatever you are telling, you should be able to justify your whatever presentation. Okay, that's what
Yes.
he meant actually. Right. Next one, Priya. Go ahead. Okay. Next. Okay. General examination. Actually, you have to put a brief summary of the history. That's what many times in the examiners request. So before
Focus.
general exam, you put a brief summary, history summary. Some,
Yes.
especially the long case sheet, if you write better. Some
Yes.
examiners expect you to write it, so don't disappoint them. Better to keep it. I
Yes.
think keep it happy. I think Robin right. So brief summary,
Yes, sir.
history
Yes.
summary, better to write before general examination.
Ye-
Otherwise, in a
Yes,
long,
sir.
okay, right. So go
Yes, sir.
ahead.
In Kerala, sometimes they ask. Yes.
Yeah,
Sometimes some examiners ask.
in our place also sometimes they will ask. Then we will be
Yes, sir. After
get
after history taking, and once the whole examination is
once
over, a
everything is
brief
covered.
summary.
Two
That's it.
summaries you are right. Okay,
Yes.
Yes.
right.
Yes.
So go ahead
Yes.
to the general examination. Let's okay.
Focus. The general examination is as follows. The patient is conscious and cooperative. She is moderately built and nourished. She has a
Well
height.
oriented, well oriented with time, place, or three things. Now, conscious,
Yes.
cooperative, well oriented with time, place, person.
Yes, in
All
person.
one sentence. That's it. We are dealing
Yes.
with the case of thyroid.
Yes. Patient is conscious and cooperative and well oriented to time, place, and person. She is moderately built and nourished. Her height is of 162 centimeter. Her weight is 59 kilograms, and BMI was calculated to be 22.5 kilogram per meter square. The vitals pulse was found to be 70 beats per minute. It was of normal rate, regular rhythm, normal volume and character. The temperature was found to be 97.8 degree Fahrenheit. The blood pressure was found to be 110 over 80 millimeters of mercury in right arm, sitting position with adult size cough. Respiratory rate was found to be 18 breaths per minute. Next slide, please. There was no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or edema. Eye signs was found to be absent. The fine tremors were found to be absent. Facies was normal and skin was normal to touch. Local
Stop.
examination.
Shreya, can we go back to her slides, please? Yeah. In vitals, you have mentioned. Sir, may I ask? SRB, sir, may I ask?
Yes, we'll finish up because it is important actually.
Yes, in vitals, blood pressure, respiratory temperature, pulse. Yes, very good. Of this, which is the most important test in vital sign? Which is the most important sign in a case of thyroid swelling?
So pulse, we
Why?
have to be careful because there will be irregular pulse in thyrotoxicosis.
So what is
What is the
Christ's
most common?
So sleeping pulse rate is higher in hyperthyroidism. So we have to check the pulse rate for ruling out hyperthyroidism.
So
So
when you
basically, you want to, yeah.
what time will check?
The sleeping at during sleep.
Yeah, what is the drawback? What is the difficulty in checking that pulse?
I'm not sure, sir.
You're not sure because you know that what is the problem? Midnight, you actually midnight, 12 o'clock, it's supposed to check the pulse. But they are very anxious people. You touch them, they'll become awake.
Okay, sir.
So many times you fail to find out the sleeping pulse rate. And many people they say that you have to give some sedation. That also again
Yes.
controversy. Give diazepam and then check the pulse rate. If you give
Yes, sir.
diazepam again, pulse rate may come down. So there is
Okay,
a
sir.
controversy about that. Ideally midnight you have to take, but only problem is when you touch the patient gets up. Unlike other patients, there are very anxious people, they get up. So there is a
Yes.
problem. Otherwise, like that, 3 consecutive days you have to take. Then take an
Yes.
average, and that makes the grading, Christ grading. You know the Christ
Yes.
grading.
Yes. Yes, sir.
So exactly that's why it is very important. Pulse rate is very crucial, especially for toxicity. Okay,
Yes.
right. Next slide. So here, these are the four signs you are told. These are the very important signs. Agree, there are around 20, 25 signs, which is only of academic interest, may be useful for your NEET entrance exam. But as a clinician, these four signs are very important. What is Telvax sign?
Because of the lengthening of palpebral fissure, there will be a staring sign. The
Okay,
patient
Staring look.
look.
carry look,
Yes.
carry look, because for contract. So look, one grief sign.
So when the examiner puts the finger, asks the subject to follow the finger, the lid will lag behind the eyeball when
When you
following the finger.
do like this, lid,
Yes, sir.
lid will lag like this. You have to do like this.
Yes.
Lid lag will be there. Okay. Joffrey sign.
The absence of wrinkling in the forehead is Joffrey sign.
Right. Ask the patient to bend like this. Then ask the patient to see.
To
This
see.
wrinkling will not be there.
Yes,
Normal
sir.
individual wrinkling will be there. It is not seeing like this. It is bend and see like this. It's
Yes,
important. Ask the patient to bend and see, raise the eyebrow. Then wrinkling would be there.
yes.
Morgan sign.
The difficulty in converging of the eyeballs.
Yeah. It is the most important. Let's see. Suggest what?
So it suggests that there is periorbital edema.
Right, like this you have to see the patient
Yes.
this one. So if you are able to see the two finger, that means it's abnormal. That
Yes.
suggests ongoing impending ophthalmoplegia or
Yes.
ectodermus involving the eye. It's the most dangerous sign. It's the most
Yes.
crucial and important sign.
Yes.
Okay, right. Uh,
You mentioned about tremors, Linsa. You
Yes, sir.
said fine tremors. The fine is actually there are two type of tremors in surgery or medicine. We have coarse tremors and fine
Yes,
tremors.
sir.
Where do you look for the tremors?
Sir, at the hands, when we keep
No.
the hands, uh,
Exactly. Can you make it fast? Yeah.
so
How?
so we ask the patient to put their hands in front and check for tremors.
How? Like this? Like this? How?
So flat, or flat to the
Yeah.
horizontal.
So like this. Yeah.
Yes, sir.
Not like this, right?
No,
Not
sir.
like
No, sir.
this.
Yeah. So flat to
Okay.
the horizontal. Yeah.
And where will you look for these tremors? These fine tremors, what we
So
call fibrillary twitching.
at the fingers and
It's at the tips here only.
tips of, yes,
It's
sir.
so fine that you will not see it. That's why we keep a paper on top of it. Then we will see actually the paper moving. Very good. That's one. Where is the other place you will look for this?
Uh,
Other than what you said, there are only two places you will look for tremors.
where else you look for?
Where else?
so at the toes, check for.
No.
So, so how will patient has to when you stretch the hand leg up little bit stressed, so you won't be able
Yes.
to get a fine tremor because already Robin towards the fibrillatory. When
Yes.
you won't have a fine movement in the toes.
Yes.
One clue is something you will do on examination.
Mhm.
On local examination, there is something that you look. It's typical for thyroid swellings. That is where you
Oral
look for.
cavity.
So is it eyelids?
Oral
Sir
cavity.
പറഞ്ഞു SRB sir clue തന്നു. He is given
Yes.
clue.
I'm
Yes.
showing actually.
Yes.
It's the tongue, okay? Tongue tremor
Tongue.
you look for. Tongue should be
Yes,
inside, not outside.
Yes.
Tongue
Yes.
within, open the mouth, tongue within, you check the tremor.
Yes.
Only two places like that's the point you have to remember. Finger
Yes.
and tongue, okay?
Tongue. Okay.
Okay.
Peter, two more things. What sort of where are you looking for this edema? What sort where? What edema?
So we're checking
Generalized.
for. So we're checking for pretibial mixed edema and
Pretibial mixed edema, or what? Anything else? Better the പറഞ്ഞു. One more P. You're right. One P is pretibial mixed edema.
X.
Second one.
Uh,
Second one. Pedal edema.
yes. Feel like.
Now, there's a reason why I'm asking. A pretibial mixed edema, where do you see? Where do you look for pedal edema?
So pretibial mixed edema we usually see in a case of hyperthyroidism.
Hyper or hypo?
Sir, hyper.
Hyperthyroidism.
So it's a
Where do you look for pedal edema? Bilateral pedal edema.
primary tertiary stage. Where you look at the pedal edema, what is the cause? Like you said, two P's.
So, for hypothyroidism.
No.
ആലോചിച്ചിട്ട് പറ, think and answer. It's a
Uh,
late
pre-
finding most of the time, but
Pretibial mixed edema is in primary thyrotoxicosis, and pedal edema is
seen it?
pedal hyperthyroidism.
Okay.
Cases of
But other than that, which is more important for us.
What do you see in secondary thyrotoxicosis? Which system is involved? That is the last
the
clue. We cannot
cardiovascular
give more
system.
than-
Cardiovascular
So what
system
happens?
is more involved. Congestive
Okay,
cardiac
what
failure.
happens? Cardiac failure, that's all. CCF. It is a late manifestation of secondary thyrotoxicosis.
Yes.
It's a cardiac
Okay.
event.
That's it.
So both you have to look for.
Yeah, that's it.
Yes.
So you have to look for both when you are thinking of toxicity.
Yes.
Mainly pedal edema because it's more common.
Yes.
Mixed edema is not that common.
Yes.
Okay, even though it is more fancily told and discussed.
Yes.
The faces are normal. What sort of faces you're looking for? Just one word answer. That's all.
A dull faces for hypothyroidism and
Mask-like faces. That's all.
mask-like faces,
Just dull
yes.
mask. That's it. That's all. Yeah.
Why
That's it, sir. I
clubbing
have no
you want to look
question.
for?
Sorry, sir.
Clubbing.
Clubbing.
Clubbing in thyroid acropathy for private thyrotoxicosis.
Absolutely. Agreed. So next slide, we'll go ahead with the examination, Robin. Good.
Yes, sir. Yes, sir. Yes.
Present.
Okay, sir. Local examination. Patient was examined after taking consent. Patient is seated in a sitting position in a well-lit room with examiner standing in front and behind the patient. Inspection. Swelling of size of about 4 into 4 centimeter present in the front of the neck, which is more prominent on the left side. It is ovoid in shape. Skin over and around the swelling appears to be normal. Surface appears to be nodular, and the lower border of the swelling is seen. Next slide, please. Swelling moves up with deglutition. Swelling does not move with protrusion of tongue. There's no visible pulsations. There's no scars or dilated veins. Pemberton sign is absent. Palpation. Swelling is non-tender. There's no local rise of temperature. Swelling of size 4 into 5 centimeters present in front of the neck. The swelling involves mainly the left lobe and isthmus of the thyroid. Lower border of the swelling is palpable. It is ovoid in shape with a nodular surface and it is firm in consistency. The margins are well defined. The swelling is present deep to deep fascia. The swelling extends laterally to the anterior border of the sternocleidomastoid on both sides, and the upper border is seen 4.5 centimeter from the sternal notch, and the lower border is seen 1 centimeter from the sternal notch. Next slide. Biggest nodule is palpated in the left lobe with a size of about 3 into 2 centimeter. It has well-defined margins. Trachea is central. Carotid pulse palpable on both sides in normal position. Focus test is absent. Examination of regional lymph nodes. No regional lymph nodes are palpable. Percussion. It is resonant over manubrium sterni. Auscultation. No bruit was heard. Systemic examination. Per abdomen examination, there's no distension, no organomegaly, no palpable mass over the abdomen, no ascites, no bowel sounds are heard. Respiratory system, double vesicular breath sounds heard over the lung fields, and there are no added sounds. Cardiovascular system, S1, S2 is heard, and there are no murmurs. Central nervous system, there are no focal neurological deficits. Sensory system is normal, and deep tendon reflexes are elicited. Summary. A 50.
Shreya, can we go to the first slide? Local examination. Yeah. Inspection. Bus. Swelling of 6%. Okay. Approximately. Yeah. Okay. Front and behind the patient, more open left side, open shape swelling over the appears to be nodular. Lower border of the swelling is seen.
No, you
In
said
a short,
uh,
in a patient with a short neck, how will you look for the lower border?
So we ask them to extend the neck.
And no, before extension, what do you do? Extension is normally you ask the patient to swallow. Same.
what maneuver you will do?
What do you call it, and how do you do it?
What maneuver? Make the thyroid
Pizzilo's method.
Pizzilo's method.
How?
Any other? Okay, that's okay, right?
How do you do Pizzilos?
How do you do that?
If before extension, before you ask the patient, look at the ceiling.
Yes.
What do you ask the patient? What? It's common sense here. Come on. Short neck, stubby neck.
Yes.
Are you sure, Linsa, this swelling is nodular? Because figure I was seeing is a single nodule. Looks like it's a little nodule from the left side, nothing on the right side. You could feel the nodules, multiple.
Yes,
nodules.
sir, I could feel it to be nodular.
How many nodules were there?
So the over the swelling we could feel 2 or 3 nodules, and the biggest swelling was about 3 into 2 centimeter.
Biggest nodule.
Yes, sir.
Nothing on the right side.
The right side was also enlarged. We could feel it we could palpate the thyroid.
Right side, you could. Isthmus. What about the isthmus?
Isthmus was also palpable, sir.
Palpable. Okay, it was not tender.
No, sir, not tender.
Okay. So, why lower body?
On inspection, 2 P's.
Yes, sir.
Okay. One is Pizzilo's method. You ask the patient to clasp the hand behind on the occiput
Yes.
and look at the ceiling. That's it. Everything
Yes.
comes out. 2. Second one is Pemberton sign.
Yes.
2 P's on inspection because that's it. We're
Yes.
not touching the patient. 2 P's. It's very easy to remember.
That's infection. Okay.
Yes.
Why lower body?
So we are ruling out any retrosternal extension.
Okay. Next slide.
Okay. Shreyas, next slide. Swelling moves up with deglutition, does not move with protrusion of tongue. What is the differential diagnosis for swellings that move with protrusion of tongue?
Which
Sir,
there?
thyroglossin cyst. Sir, any lymph nodes which are palpable, the pretracheal, prelaryngeal.
It's a very simple question. What are the swellings, differential diagnosed swellings that move with protrusion of tongue?
So
You are given as
sometime-
thyroglossal cyst.
Yes,
So
sir.
the idea is before you answer this question, how does it move with protrusion of tongue? So if the embryology is correct, you will get the answer to the question. Lymph nodes, are they attached to something
No,
from
sir.
foramen cecum to something?
sir.
So,
Oh, yes, sir.
How
even
it-
thyroid swellings also will move, but minimally.
Sir, can you repeat the question? With
Which are
protrusion
the
of tongue.
swellings with protrusion of tongue, not deglutition?
Okay, sir.
Lymph
Sir,
nodes, okay, it is attached to this thing. Okay.
yes, sir. Thyroglossin cyst will move with protrusion
Agreed.
of tongue.
Next.
Any
What is the embryology? Where is the tract end?
Where the
Sir,
track ends?
That is a clue to the answer.
isthmus.
Isthmus just everywhere. Which area of the?
Over below. What it passes through? Track passes through what?
How does it? Where does it end?
Sir, I'm not sure.
What is the treatment for thyroglossal cyst?
The removal of the cyst from the.
What is the name of the procedure?
What it is called as? What operation it is called as? Okay, you can find out. We will tell the answer. Cyst
Yes.
trunk operation. Okay,
Yes.
we'll remove the entire track with the
Cyst.
piece of the required what passes
With-
through.
With something. Yeah, that is important.
Yes.
So the clue is there itself.
Yes.
So at above,
Thyroid,
at
sorry.
or below. So upper subhyoid bursitis. There is one more differential diagnosis. What is that? The clue is in something in the midline.
Sir, dermoid cyst.
Very good. Sublingual dermoid cyst. It's all in order like this. It goes like this itself.
Yes.
Thyroglossal cyst. The clue is above, at
Or below the cyst.
Atra Appa sub hyoid, Mathe the mole,
Mole.
and here it comes here. So it's
Yes.
very simple. Yeah.
Yes.
There is a subtle difference. It is there in DAS. One small line at the neck swelling, they have written something. How to differentiate thyroglossal cyst from a sublingual dermoid.
Yes.
Both will move with protrusion of tongue, but thyroglossal cyst moves very well with protrusion, and the sublingual dermoid moves very feebly.
It's a main
See,
thyroid cyst. Okay.
Yes.
Why
yes,
thyroid moves with the deglutition? What is the reason for that?
It is attached to the cricoid. It is attached. The constrictor muscles are involved in swallowing, so it is attached to the cricoid cartilage, the thyroid cartilage, by the Berry's ligament. So when the
What is
deglutition
Berry's
happens,
ligament?
so it is a condensation of the pretracheal fascia to the cricoid cartilage.
Okay. Which
and
part is condensed actually?
which
Sorry, sir.
portion?
Which part of the
Which portion?
is condensed?
So the posteromedial part of the,
Posterior medial or posterior lateral?
I think it's posterolateral.
Superior part, posterolateral and superior part mainly.
Yes. Sir.
Okay. Is a false capsule or true capsule? This petrichal fascia is.
Sir,
If you have read,
No?
if you have read SRB sir's new edition, you will know the answer to this question.
So is it a false capsule or true capsule?
Sir, it is false capsule.
A false capsule, absolutely right. Not true capsule.
Absolutely right. Yeah.
Agreed. That is most of the literature. That answer is sufficient for all students and don't require to have much more detail. Why it moves? You are told properly. Perfect answer. So palpation. You go ahead with the palpation. Tenderness. Why is it?
So again, if there is any, if it is thyroiditis, we might get tenderness.
Okay. In
Sorry.
advanced malignancy also it may be tender.
Yes.
Localized temperature also same. Right.
This lower border of the swelling is palpable. How did you check that out? It's a confirmation to lower border on inspection. How did you
Yes.
palpate?
So extend the neck and then we check. We keep a finger below the swelling and ask the patient to swallow. If
It is very simple. Yeah, it's like a poem actually. You keep your index finger in the hollow,
Yes.
and you ask the patient to swallow.
Swallow. Yes.
It's very
Horizontal.
simple.
Yes.
Keep horizontal.
Yes. Sir.
And ask the patient to swallow. That is an important thing.
Yes. Sir.
Don't ask the patient to swallow. Otherwise, you won't be able to feel it.
Yes.
During swallowing, you have to
Feel the retrosternum.
Okay,
Yes.
right, absolutely right. What Robin told is absolutely right.
It's very easy to remember that also. You put the finger in the hollow, you ask the patient to swallow, and you will be able to feel it. It's very simple. And in the textbook in DAS, it is written to get below the swelling. That is
Yes.
the only place other than hernia they have said to get above the swelling. This is to get below the swelling. Okay. Yes, sir. It's okay. I think she has covered the main points here. Nodular surface, firm in consistency. Okay.
Why you said it is a deep to deep fascia based on what clinical
So
findings?
on extension, the swelling becomes less prominent when the patient.
Okay, but that is not the we won't be able to very clearly. All olden days, when we are PGs, we are asked to because you have to put the tongue up and press the palate, then like that. All those things are very difficult to make out, mostly on theoretical rather than clinical.
Yes.
The one way is to find out whether it's a deep to sternocleidomastoid muscle or not.
Yes.
If it is a deep to sternocleidomastoid muscle,
It's
by
deep to
contracting the muscle like this, it has to be deep to deep fascia.
the deep fascia.
Deep
Yes. Sir.
fascia encloses the sternocleidomastoid muscle.
Yes. Sir.
No swelling will be superficial when if you consider that it's deep to sternocleidomastoid muscle, it has to be deep to deep fascia.
Deep fascia.
So exactly, naturally it becomes. We don't
Yes.
have any other clinical evidences like extension. It's very difficult to make out. It is just
Yes.
more theoretical rather than actual, I think, Robin.
Yes, sir. Yes, sir.
So,
Linsa, just sir, as what he has said, it's theoretical only. How the plane of the swelling for any swelling is important.
Very
We just want to know.
important, yeah.
We just want to know where it is. So,
Yes.
what is that name? What is that test that you do? Like, sir, just showed and went away. I just want to know the name of the test. In the old days, we used to do this to check the plane of the swelling in the neck region. What do you call it? The clues in that muscle, sternocleidomastoid. How?
So is it Lahey's method?
No. Leahy's method is L for L.
L.
Leahy's for
Like-
lobe Leahy's.
we are going to discuss anyway. It's different.
Sir just now showed something, no?
Yeah.
He showed like this. What?
Yeah,
what?
like this, you have to just contract. Then you will know that it deep to the
Yes.
contract the muscle.
It's called the
So
chin
against
test.
resist.
Like this. Okay.
It's called the chin test. So bilaterally sternocleidomastoid in one form. The old days, what we used to do is we'll keep the hand here, ask
Against
the patient to
resistance,
contract against resistance.
Yes.
Either like
That's
this
chin
for
test.
one side. Actually, both side like this, whatever the way. Then you'll be able to see. So
Yes, sir.
key muscle in the neck is sternocleidomastoid muscle for any neck swelling. So
Yes,
always
sir.
you have to interpret any neck swelling in relation to the sternocleidomastoid muscle. It's the key muscle that gives a lot of clinical information. Okay,
Yes.
right. So
Yes, sir.
next slide.
Cockers absent. Okay.
Leg
I
distributed
assume
organ.
we assume you know this Cockers test and Leahy's method, Kryle's method. You know all this. We assume we
Yes.
won't waste time there. Alle.
Yeah,
A Cockers test we are looking for basically trachea.
Basic track.
We are looking for
Strider.
trying to listen for an inspiratory strider.
Strider.
Okay, you push from one side.
Pemberton's sign, although
Okay.
people may ask Leahy's method how to do, Cocker's test how to do, then Pemberton's how to test how to do, Kryle's method of examination. Many people palpate with the thumb
And thumb.
or index finger
Yes.
just to feel it like this
Nodule.
for any nodule. All the things,
Nodules.
all the names you have to remember that anyway you can read out and find out. But it's very, very important for all students when you present thyroid because it's a long case. So
Sir, one question she mentioned on carotid pulse. Last question here. What is the significance? You said palpable on both sides in normal position. Why did you mention like that? Why
So,
did you?
and the
What's the norm? So look, if you write like this, they will ask you first what is normal position of carotid pulse.
yes, sir. At the
What's the
anterior
answer?
border of the sternocleidomastoid against the C6 tubercle.
So the idea is you draw a line, imaginary line from the upper border of the thyroid cord, from here, and it ends in the lateral body here.
Yes.
That's a C6. What do you
Yes.
call that? And you palpate it against what?
The C6 tubercle, sir.
no, C6
What do you call the tubercle?
Yeah, C6.
Uh,
Anatomical surface marking is like Robin rightly told. Thyroid cartilage, where it joins that line joins the sternocleidomastoid. That's where you will palpate. So which
Yes.
carotid you are feeling? Common, external, internal.
so a common carotid artery.
Common. When you say carotid, it is understood logically that, or it is always common carotid.
Common carotid artery.
Right. So of course,
You're right. It is a C6. C6 is a very important point in the neck. It has
Yes.
a lot of landmarks which is coming there. The name of the tubercle you have not told us. You can refer, no problem. Because
Yes.
you're answering all the questions, so we just asked just to confuse you. That's all. There starts with C only.
Yes.
Cervical
Thank
C
you.
tubercle,
for
name
C.
of the tubercle.
It's a
Sir?
French name.
Name of the tubercle.
Name of the tubercle.
I'm not sure.
Okay.
That's a very. What is the inference here? What is the importance? Why did you say this? Palpable on both sides in normal position.
So there is no infiltration to the carotid sheath. So,
It is not always infiltration.
sir,
It's a pushing, deviation.
deviation.
Get deviated.
There are
pushed.
two differential diagnoses when it comes here.
Yes.
One, you have it's always like that. It's a benign swelling, and you have a malignant swelling.
Malignant swelling.
Now, like Sir said, a benign swelling which is very large,
Mm.
a large, long-standing multinodular goiter will push the carotid from its normal position laterally.
Yes.
Okay, so it will be palpable, but shifted.
Shifted.
But when it comes to malignancy,
It will be deviated.
Yes.
deviated. But when it comes to malignancy, it is not deviation. It is like you said, infiltration of the
Infiltration.
carotid sheath. So you will not be able to feel it in its normal position.
Yes.
What do you call that sign?
It's the berry sign.
Very side.
It's a berry sign. So when in such a situation, when you are trying to feel it against the C6 tubercle, you are not able to feel it. Do you say berry sign positive or berry sign negative?
It's the berry sign negative.
Berry sign positive is when that thing is absent.
Yes.
Yeah.
Okay.
Pushing back.
the opposite.
Yes.
Yeah.
And very sign, when it is positive, it suggests that it is a malignancy. Not only
Yes.
malignancy, it is advanced malignancy. So it becomes like staging if it says T4 B like that. Okay.
Yes.
Always suggest advanced malignancy. Of course, occasionally visual
Yes.
thyroid also causes encasement and won't be able to feel. But very sign by principle is usually related to the carcinoma thyroid, which is advanced actually. That's the
Yes.
point you have to remember.
Yes.
Very sign suggests advanced carcinoma thyroid, not just carcinoma thyroid. Okay, advanced carcinoma thyroid. That's the point you have to remember. Okay.
Very good. You have covered everything. No regional lymph nodes. Okay, very good. Which lymph nodes?
All those things you know.
Which is the first lymph node that is involved in carcinoma thyroid? What is the
So the
name of the
Delphian
thyroid?
lymph node,
Yes, Delphin is the name, eponymous name. What is the clinical name?
prelaryngeal.
Yes, very good. Yes, okay.
The
Yes,
single node between the two cricothyroid. Agreed.
yes,
And other things, everything you have mentioned, all those tests we are not going to discuss, and you can read out. It's very, very
Yes.
important.
Yes.
Then neck lymph nodes also you have mentioned. Whatever your neck lymph nodes you are palpating actually secondary lymph nodes. They're not primary lymph nodes. Even though first lymph node is Delphian node, clinically it is not usually palpable. That's the point you have to remember. So when it is palpable, you look for always secondary lymph node, 2, 3, 4, 5, like that. Okay. So regional lymph nodes you already mentioned. So next slide, Shreya. So why you want to do percussion for the manubrium?
So it is to check for retrosternal extension.
Okay, retrosternal extension, percussion. There are other methods also. You said lower border also. This is very more important. Bruji, where you look for Bruji?
So superior pole of the thyroid.
Okay, why superior pole?
So because superior thyroid artery is more superficial and it goes over the superior pole of the thyroid.
Both three.
No. Superior thyroid artery is not superficial. It is the first branch that comes out from the external carotid artery. One, two. That superior thyroid artery breaks into two more.
Yes.
It branches into anterior and posterior. The anterior one is very large. You're put
anterior surface of the thyroid, whereas inferior thyroid enters the posterior surface of the thyroid.
Of the thyroid.
Posterior. You will not hear it. Yeah.
Yes.
That's right. Oh, very good. There are 6 questions they will ask probably. Yeah.
Palpation. Okay. Which is where thyroid has got more blood supply. How much blood supply to thyroid occurs from the superior thyroid artery? How much from the inferior thyroid artery? What is the percentage of gland supplied by the superior thyroid artery? What is the percentage of gland supplied by the inferior thyroid artery? If you know, you tell. Otherwise, I will tell.
Sir, I'm not sure. I don't know.
30 to 40% only supplied by the superior thyroid artery.
Yes.
Main supply around 60, 2/3 is by the inferior thyroid
artery.
You have to remember. Okay.
Yes.
Right. So trill and Brie in the superior pole, not in the inferior pole. You already.
Yes.
So next slide. Okay. Systemic examination. Why abdomen examination you want to do? Why organ? Which organ you are interested?
So, the liver, if there's any metastasis to be.
Okay. Then
which carcinoma is notorious for that?
Which carcinoma?
Liver metastasis. Relevant to thyroid.
Follicular carcinoma.
No. In a very young patient. Very young. I did not say young. No, I didn't say young patient. I said very young patient.
So medullary carcinoma.
Medullary carcinoma, thyroid is notorious for liver. Papillary carcinoma is for lung.
Okay.
Follicular carcinoma is for bone.
Bones.
Papillary carcinoma, anaplastic carcinoma spread to lungs and yeah. Okay.
Yes.
Okay, sir. That's fine, sir.
Okay. Respiratory system. Why cardiovascular system is important? So splenomegaly is also important. Remember, in toxic thyroid, Hashimoto thyroiditis, autoimmune disease, splenomegaly is quite common. Okay.
Yes.
It's a reason why you want to look for the spleen. So why you want to look for also important. Same thing. Why you want to look for the central nervous system examine?
So deep tendon reflexes are delayed in hypothyroidism. So
it is exaggerated in the hyperthyroidism also.
Yes.
So next slide. Summary, you already told. Presenting progressive in nature, to the discomfort while swallowing, and on avoid non-tender swelling. Present in swelling moves with nutrition, has a neutral surface, firm in consistency, margins are well defined. Agreed. So it is mobile, horizontally mobile. There is no independent mobility for the thyroid. But
Yes.
a thyroid which is not infiltrated, it will move horizontally. Not
horizontally.
Of course, isolated cases may feel the upward mobility. Other by and large, by principle, only horizontal mobility will be there for thyroid. Okay.
Yes.
Right. Agreed. So what's your diagnosis?
I think this is a multinodular goiter in euthyroid state.
Multinodular goiter in euthyroid. Why said it is why said it is euthyroid?
So there is no symptoms of any hyperthyroidism or hypothyroidism in the patient from history.
Okay. Why said it's a multinodular goiter?
So on examination, we were able to feel the surface to be nodular.
Okay. So with the complication of euthyroid, you said already euthyroid. My leading question: can it be malignant?
So there were no features of malignancy, suggestive of malignancy.
So if it is malignancy, which malignancy it can be?
So most usually it is papillary carcinoma in long-standing cases of multinodular goiter.
Papillary carcinoma occurs in a long-standing cases. Multinodular goiter. Papillary carcinoma develops. Which malignancy develops in a pre-existing multinodular goiter?
Follicular carcinoma.
Follicular carcinoma. But here it is, what is the duration, total duration?
So 2 years only. So
whether it be per se de novo papillary carcinothyroid. Can this be a per se de novo papillary carcinothyroid to begin with? Not a case of multinodal goiter turning into the follicular carcinothyroid.
I don't think so, because there was no rapid size increase
You
or
need
any
papillary
features.
carcinothyroid always to become rapidly progressive.
No, sir. It can be
Can be slow
taking.
progress. You see,
Yes.
any thyroid swelling can be malignant unless proved otherwise. Size is not a
Yes.
criteria. Duration is not a criteria.
Okay.
Age is not a criteria. Small size also maybe. Long duration also maybe. Big size also maybe. So you don't require to wait for the lymph node to get enlarged also. Don't ever say that
Yes.
because there are no lymph node, it is not malignancy. That becomes
Yes.
stage 3.
Yes.
Don't wait that to happen. So any thyroid can be malignant unless
Like that.
otherwise. That is the common dictum which we were taught like that. Okay. So it still could be papillary carcinothyroid. Remember, 2 years is not a long, not a very long duration as for papillary carcinothyroid, unlike
Yes.
other malignancies. Okay.
Yes.
So, Robin,
Yes, sir.
so they should be able to tell that it should be not follicular carcinothyroid. Papillary carcinothyroid should be a differential diagnosis, I think. No.
Yes, sir. Huh.
Mm.
The only thing is a 50-year-old lady, then 2 years gradual onset and progressive. That's all. Huh.
That's
Okay.
what. This is about 50 year, no? But still, it's a
Hmm.
commonest malignancy. Only thing is how to, because the 2 years MNG turning into malignancy without a
Yes.
rapid increase in the size, that is the point to tell how to justify it. So, next slide, Shreya. Oh, that's what diagnosis is there. Slide. Next
Right.
slide.
Next slide.
How will manage?
How to investigate this
How
patient?
will
Huh.
investigate?
Yes, sir. Routine blood investigation, which includes complete blood count, blood grouping, RH typing, and random blood sugar. Thyroid function tests must be taken. TSH, free T3 levels and free T4 levels. An ultrasound imaging of the neck must be done. Ultrasound guided fine needle aspiration cytology must be done. X-ray of the neck in AP and lateral views. X-ray of the chest, ECG, and an indirect or flexible laryngoscopy must be taken.
Right. Wait. Now, why complete blood count you want to do?
So if this we have to look for any signs of inflammation in case there is any thyroiditis.
Okay, one. Second thing, if patient is toxic, you should have a
Yes.
baseline total count because when you
Yes.
start antithyroid drugs, patient may go for a neutropenia and total count, reduced total count, pancytopenia, and so on. All those problems of the bone marrow suppression will be there.
Yes.
So that is why. Then why you want to do thyroid function test, and these normal values should know. I will not going to discuss that. You can always read out. What is at least remember the normal value of the TSH is very important. What's the normal value of the TSH?
So it is 0 to 5 milli.
That's the point you have to remember because TSH is most important. If it is higher in hypothyroid, it's lower in the hyperthyroidism. So other levels, free T3, we can always go through the book and remember in the exam they will ask. So just revise them and always recapitulate, keep it in your mind. Why ultrasound is important in the neck thyroid swelling?
So it is to check the size, the surface, the number of nodules, the vascularity of the and the echo texture of the nodules.
Okay. Anything else? To
So
look
the location also.
location, vascularity, carotid, everything. Look for the lymph nodes.
Yes, sir.
There are lymph nodes are very important investigation. Ultrasonic FNAC is absolutely right. FNAC is the investigation, not Rupert biopsy. Like carcinoma breast or breast lump, now currently it's a Rupert biopsy.
Super biopsy.
Thyroid is still FNAC. Okay. So which malignancy FNAC is not that useful?
Anaplastic.
Anaplastic
Sorry, follicular
FNAC?
carcinoma, sir. Follicular carcinoma, sir. Because capsular and vascular invasion cannot be seen on FNAC.
Okay, right. You wanted to check for X-ray?
So X-ray neck is just to rule out any retrosternal extension.
Okay.
And
Any other reason? X-ray neck?
so any microcalcification can be seen.
Calcifications you can see. And deviation, tracheal deviation.
Deviation.
Absolutely right. Okay. Touch X-ray, ECG, why?
So if it is multinodular goiter, we most probably will be going to surgery. So we have to keep ECG of the patient.
Okay, thyroid assessment should be there for anything, of course. English should do that mainly second toxicology if it happens into the clinical diagnosis. Okay. So laryngoscopy, why you want to do?
If this person had a childhood history of any viral fevers and they may have had a recurrent an occult recurrent laryngeal palsy, so to rule that out and to keep it for recording purposes, we'll go for a flexible laryngoscopy.
Okay, now strobo laryngoscopes are available where you can visualize
Yes,
it nicely. So what word you will use to see the vocal cord movement? There again a
sorry,
common
sir.
task. What word? A, E, A, U, whatever it is. In doing which word is important to see the vocal cord movement?
Uh, Sir, abduction
No,
is
no,
what
which
it should.
word? A or E or A or B or
Which word?
Uh, I think E sound
E,
only.
because it's the abductor.
Yes.
It causes the very clear cut visualization. So you will usually when you do this, only ask the patient to say E.
Yes.
Tell E like that. Okay, the E word is important. Okay,
Yes.
so that you can see the mobility very well. Okay,
Yes.
so Robin or Robin, any other things?
Uh, so here, everything is covered. The
Covered.
most common, just for revision for the listeners, most common screening investigation is TSH between hyper and hypo. Once you get it, if you want to differentiate between T3 T4, you go for better always is free level rather than the bound form.
Right.
Okay.
Yes.
Ultrasound neck, please read this because it's a very vast topic. It is there in SRB, SR's
Yeah,
new edition.
it is there.
You should know the indications for ultrasound neck, solid versus cystic. Why it is important? It's just makes it easy for students. We call it triple assessment. Any thyroid case, you go for TFT. So you differentiate whether hypo, go for imaging, then you go for histopathology. That is FNAC. Now, if you have a solid or cystic both combined, Linsa,
Yes.
where will you do the FNAC? Where would you prefer to do FNAC?
Which part?
Cystic or solid? Cystic or solid? Which one would you prefer? Simple question.
Uh, Sir, at the solid part, we should do.
Because it's called fine needle aspiration cytology. So would you prefer cystic where you get cells or solid where fine needle aspiration cytology?
So I think it should be cystic area.
Shall we lock it?
Yes,
Shall we lock it?
cystic. Yes, sir,
You
cystic.
were right the first time. I just
Okay.
twisted it and you
Okay.
got it wrong this time. It is a solid
Yes.
only. You
Yes,
want
sir.
the solid portion.
Solid
Cytology is cell saying,
Sir. Yes, sir.
Okay, they call
It
it
should
and
be the solid versus
both
cystic.
combined called complex thing.
Yes.
Okay, now like biroids in the breast disease, here thyroids you have got
Thyroid.
thyroid imaging reporting and data system. There are 5 grades. In biroids, it is 6th grade. Here it's a thyroid. We are not going to discuss detail about that. You can always go through the
Yes,
book.
sir.
In the book it is there.
Yes, sir.
But remember,
Sir, I think
thyroids are there. Only
she's
five
covered, yeah.
grades are there. Where biroids
Yes.
6th grade. Okay, the difference you
Yes.
just remember. So sometimes CT neck we will do. Olden days CT neck they were telling because iodine you are using again iodine will interfere with the imaging all those things. Now currently CT neck is accepted investigation as far as thyroid is concerned. Sometimes in the exam they will ask what is the problem because we use the same iodine contrast. So when you image thyroid with the iodine contrast because thyroid is the basically iodine related organ. There will be
Yes.
some problem with the imaging. That's what they say. But still, now currently radiologically it is accepted investigation. Otherwise, you can do always MRI. Okay.
Yes.
So next slide is treatment. Now suppose it is Robin will going to discuss. Suppose it's a papillary carcinoma, right? FNAC shows some of bodies and orphan nuclei. So what is your management strategy? If it's a commonest malignancy,
So papillary carcinoma.
carcinoma, absolutely right. So
Yes.
management strategy, treatment.
So we will stage the carcinoma. If there's any lymph node metastasis, we'll do a modified radical neck dissection, or and then we will send for after surgery we will check for the thyroid. We'll take the person for levothyroxine suppression. So after that we will check after a period of 6 weeks, we will check if they have any ectopic thyroid tissue left with the help of
Ectopic. No,
You are really simple thing. You are confusing the issue so much. It's very simple. Always you do total thyroidectomy.
Yes.
And if you think there are lateral neck nodes are present, there is a controversy about the lateral neck node, central lymph node dissection.
Neck lymph node dissection. Yeah.
Dissection, wherein you clear pre-laryngeal, paratracheal, central compartment completely, because one hypothesis says that in 80 to 90% of thyroid malignancy, especially differential thyroid cancers, these central compartment lymph nodes are, even though clinically not palpable, microscopically they are involved. So those people always say that it is better to remove this and clear the central compartment.
Yes.
The problem with that is in those patients will go for very commonly dreaded hypoparathyroidism and recurrent glandular palsy are a possibility. So there is a controversy. Always you can tell because it is in node, you can do it. The only thing is lateral compartment dissection. It is not the MRND. It's the lateral compartment dissection where 2, 3, 4 AB, sometimes 5. You will remove it. Okay. So that is when it is involved only sonologically and FNAC of the lymph node. Understood?
Yes.
Sonologically, if all features are says that lymph node probably involved, then you will do a lateral compartment
dissection.
Okay, like that LCC and CCN. CCN is a controversy. Always you can say I can do it. I am going to do it because it is very commonly involved. So I'll have a very good clearance. Understood? So there is no confusion. Don't get to pick all those very standard terminology. Same thing use it. Okay.
Yes.
So then after that, what you will do after surgery?
So after surgery, we have to follow up with the patient. We have to do ultrasound, and then we have to check their
What is the
TSH
size
levels.
of the swelling? Size of the tumor swelling here you said 4 to 5 centimeter, no?
Yes,
so this patient 5 centimeter thyroid, papillary carcinoma thyroid, you have done the surgery. Then how will do the adjuvant therapy? Will you give the adjuvant therapy or not? If you are giving adjuvant therapy, what adjuvant therapy you are going to give?
So because this is greater than 2 centimeters, so this will be stage 2 carcinoma. If it is papillary carcinoma, then we'll have to follow up the patient. After total thyroidectomy, we'll have to send them for a whole body scan with radioiodine uptake.
Requested for whole body thyroid scan you want to do, is it okay?
Every patient you want to do whole body scan. There is a protocol for this follow-up of well differentiated thyroid cancers. You have done total or near total thyroidectomy, preferably that, like sir said. Next, neck dissection, preferably central. If the central is not there, you look for the lateral functional neck dissection, which is the old name, preserving the 3 people: muscle, 1 nerve, and vessel. Okay, very easy to remember that. Okay, so that is done. Once it's done, papillary carcinoma is what type of a tumor? Is it TSH dependent or TSH independent?
So it's TSH independent.
I just a little bit you get confused.
Yes.
Involuntary laugh has come. It is always TSH dependent.
Dependent, yes.
So why do you give, what sort of thyroxine do you give papillary carcinoma patients? What type of thyroxine?
So after removal of thyroid, you have to give thyroxine.
Yeah.
2 types of doses are there. What are the 2 types of doses?
2 types of doses. Which one would you prefer to give?
Levothyroxine.
No,
levothyroxine you give, but what type? Doses. Sir is asking what dose?
So early morning dose.
No. I'm not asking about before food, early morning, thyroxine, all those things. What type of dose? There are 2 types. One is maintenance dose, where you and me has to have a thyroxine always, daily.
Yes.
So when you remove entire thyroid, somebody has to take the thyroxine. Otherwise, they'll go for a severe hypothyroidism. So that's called maintenance dose. Another one is that's what Robin is interested. Another one is that's what he's asking.
Now we have a tumor which is papillary, which is TSH dependent.
Yes.
So what do you want to do?
So we need to see if there's any remnant tissue.
Now, what is the meaning of TSH dependent?
Sorry, sir.
What is the meaning of TSH dependent?
On the activation of TSH will activate.
Optimum level of TSH should be there to these malignancy to proliferate, these cells to proliferate.
Yes,
if the TSH is very low, even though there are few cells which is retained or whatever it is, cells will not proliferate. That's the concept. That's the TSH dependent. So if you make it TSH very low, what you do?
So these other cells won't proliferate if they are very low.
So how will do that?
So by TSH suppression.
Yeah, TSH suppression. So you have to suppress the TSH. How to do that?
Yes. So we give them the dosage of thyroxine.
That is what we are asking, Linsa. What do you call that? How much will you give? Like just give us that English term. Sir gave one clue. One type is maintenance.
Maintenance, yes.
You remove the whole thyroid, you want to maintain. But if you want the TSH very low, you don't want it to stimulate. What you want to do then? If you don't want to stimulate one person, what will you do? What will you sit on that person and do?
So,
You have to
block the person.
You have to
You
give
block. What is the other?
of L-thyroid. TSH suppression. Suppressive dose.
Suppression. Yes, suppression.
Very
Yes,
high dose,
suppressive.
suppressive dose. That is the
Yes.
dose that we will give.
Yes, sir.
So usually it is around 200 to 300 microgram per
Microgram.
whereas maintenance dose is only 100 microgram.
100 microgram. Yes.
So you have to give a suppressive dose. That's the two types of doses: maintenance dose
Yes.
and suppressive
And
dose.
suppressive
In
dose. Yes.
DTC, in DTC, suppressive dose you have to give.
Yes.
All other benign conditions when you operate, you have to give maintenance dose.
Maintenance dose.
So here it is a suppressive dose. That's all the reason why Robin has brought TSH dependent. TSH has been telling TSH dependent to get your answer. Okay. Because you have suppressed the TSH. Without TSH,
Yes.
malignant papillary carcinoma will not proliferate. Okay.
Yes.
So this is what you have to give. Now, additionally, you may have to give a radioiodine therapy because it is more than 4 centimeter. There are other criteria. I'm not going to tell that. In such situation, you have to do a TSH. You should not give L-thyroxine initially because you have to make TSH more than
30 milliliter.
30 units. So you have to give. After that, once it is more than 30 units, you have to give the radioactive iodine therapy dose. Okay. So how to give radioactive iodine therapy? Which radioactive iodine is used?
The 123 is used for
therapy?
So 131. Iodine
Always
131 for therapy. Yeah.
The 123 if at all for diagnosis.
The diagnostic
Currently
purposes.
they used to do. Currently both only 131 is used. 123 only for diagnosis. Therapy
Diagnostic purpose.
131. Okay.
Yes.
What is the half-life of iodine 131?
Sir,
You can read it. I am not going to do unnecessarily. Don't want to drag it. But iodine 131 is given. It is usually given orally. Remember, either liquid
Yes.
or solid.
Oral.
Okay. So only thing is you have to ask the patient to abstain for 3 days. Currently 3 days isolation. Olden days
Isolation.
7 days. Then trash bags has to be used for excreta. All those things. Avoid
Yes.
on eating something, so chocolates or something, because so that salivary gland will not go for a if you have to stimulate the salivary gland as such. All those things are there in the book. You can go through it. But important thing is radioactive iodine therapy. Iodine 131 therapeutic dose you have to give. Usually one dose is given. Eventually you study again later after 3 or 6 months. If still needed, further dose can be given later period. Okay, right. So carcinothyroid is the main thing they will ask in theory question. Also they will ask. It's a major question.
Yes.
Individually papillary carcinothyroid, follicular carcinothyroid, medullary carcinothyroid. All those things will be asked as a short note also. So all those things will be asked in the exam. Depending on the examiner mood, they may deviate whatever way you want.
Yes.
So the next question is Robin, complication. Let me enumerate complication thyroidectomy. You don't want to give detail about that. I think Robin, is it okay?
Yes, sir. Yes, sir. Okay.
Just
Yes, sir. Because the carcinoma thyroid is actually a it's a very long topic because isotopes itself takes a long time. The treatment, all the students have to read it.
Yeah.
You have to, once you do the surgical management, you have to look for remnant thyroid. That's what we call remnant thyroid ablation.
Radioablation.
Radio remnant.
Then we have that itself in the radioactive chapter itself, there are different modalities, different doses of what we give. We don't have time to cover it, but we will try to do it sometime next thyroid case or something. We'll try to discuss. So thyroid is a huge topic.
Huge topic. It is.
Just a fun question. Sir already pointed it out. You said iodine 123. Sir corrected and said 131.
Yes.
He corrected also saying that it's better to use something where you can have both diagnosis and therapeusis. Right? Because iodine 123 is only diagnosis. My question is, which is that substance in iodine 131 which is used for diagnosis and which is the one that is used for treatment? When the isotope splits.
So the substance that is used.
Yeah, the substance in iodine, the isotope 131, when it splits, the tracer when it splits, which is used for diagnosis, which one is used for treatment? Who is your favorite Avenger?
Sir, Iron Man.
Huh? Iron Man.
Man.
Then you won't get the answer to this question. If it is Hulk, probably you might be able to answer that question. But it is not gamma radiation. No, it is beta and X-rays. There are two.
That point you have to remember. Only gamma
that you should know.
and gamma. The beta which is important. Okay, so which rays are important? Okay. Okay, the leading question. That's important for your MCQ also. So
Yes,
which your areas are involved in each. That's important. It's there in my book. It has a chart for that. It is
yes.
there. You can always go through it. Okay.
What is the
So
role of thyroglobulin? Or any role for thyroglobulin in a well-differentiated thyroid carcinoma investigation or post-treatment, something
it's a very
follow-up or so?
important question actually. That's a very important investigation, a follow-up.
So it's a follow. Yes, it's a follow-up. We use it to estimate if there's any remnant cells which are.
Remnant, either there is normal tissue or there is a tissue that you have left behind, or unfortunately there is a metastatic thing. Three things.
Either lymph node or local recurrence. Local
That's it.
recurrence or lymph node or metastasis. So all these things are
Okay.
important for to assess by thyroglobulin. If serum thyroglobulin is undetectable or very low, that means they're less likely to have any of these things, lymph node mets or local recurrence or metastatic elsewhere. Okay, that's why it is very, very important, sensitive investigation for follow-up.
Yes.
Not much role for the diagnosis. Okay, it is essentially a follow-up marker, very good marker actually. So thyroglobulin is a very commonly asked MCQ question. Maybe after the short note, remember, you have to know serum thyroglobulin. Okay, so values you have to know. Why it is important also, you have to know. Okay, so just enumerate complications before we winding up.
Complications of
Thyroidectomy.
thyroidectomy. So immediate complications are hemorrhage.
Okay.
Then recurrent laryngeal of palsy might happen.
Okay.
Then infections of
Okay.
the
No. Before going infection, it's not that common unless patient is diabetic.
yes, keloid of the skull. I was
It's a later
that.
period. Before that,
Yes.
you said
Linsa, whenever an examiner asks you, they will never cut marks for taking a little bit of time to think.
Yes.
Complications. So all complication surgery are divided into two sections. Either
Yes.
you have early or you
complications.
have late
Late
complication.
complications.
So which is the most common immediate complication that can happen?
So hemorrhage
And
of
which are
the
the hemorrhage, slippage of ligature or whatever it is. Yes, Srirama
that's
collection
important.
is the respiratory option. That's
Hypertoning
yes.
sometimes.
yes, sir.
Okay. So how to manage? I'm not going to immediately shift and open the deep fascia. That's a part of the thing.
Yes.
And hypoparathyroidism, you are not told. It's very common. It's much more common than the recurrent longitudinal pulse actually.
Yes, yes.
Maybe temporary, permanent. You have to do serum calcium.
Temporary, yes. Hypoparathyroidism. Yes.
Parathyroid.
What is the treatment for hypoparathyroidism if you diagnose it within post-op day 2?
No.
It's a very simple way to remember it. What is that substance? Just give us the name of the substance. Hypoparathyroidism, you understood, right? Parathyroid is
Yes, sir.
missing.
Missing. Yes,
Two
sir.
pairs of it, ball 4 we have taken off. Patient starts developing
Parathyroid. Hypocalcemia.
hypocalcemia. Yeah. So
Yes.
what do you give? What's the
Calcium
treatment?
gluconate.
Calcium gluconate. You give 10% calcium gluconate, 10 ml over 10 minutes. Over. That's simple answer. 10, 10, 10.
10. Okay. Right. So that is initially, eventually you have to give oral calcium, vitamin D. Then you have to do the follow-up. Commonly it is temporary. Two can be permanent eventually if not for more than 6 months. There are criteria which you can always read up. Then
Yes.
another thing is thyroid storm, which is not that commonly seen, but more commonly asked as this one. Maybe a short note in the theory question also. Main thing is hyperpyrexia and circulatory collapse. These are two features you have to remember. Hyperpyrexia, circulatory collapse, and cardiac events. Okay. The three things you have to remember. Yes, where thyroid trauma is considered, high dose steroid, sponging, paracetamol, propranolol, and adequate perfusion. All those things are treatment part which you can always read it. Okay.
Yes.
These are the four important things you have to remember. Hemorrhage, laryngeal edema, parathyroidism, recurrent palsy, thyroid storm. There are so many other things. You said keloid, wound infection, all those less common that you always eventually can be dealt with. These are the life-threatening or requires a real monitoring and management concepts. Okay,
Yeah.
these five complications are very crucial, very important. You have to always remember.
Yes.
Right. So this is the multinodular goiter, youth state. Diagnosis is absolutely right. So examination, so many signs are there: Leahy's method, Pizilius method, Kyle's method, Pemberton sign, Cocker's method, which you are not going to discuss. Always read about it. It will be asked in the exam in the present case. As it's always a long case. The lower body is very important. Carotid, although the whatever things we have discussed well, and always difference that is the carcinoma. Remember, which is suitable to this patient You have to always come out with the answer. Accordingly, discussion may be led that way.
For-
Okay. So accordingly, you should be able to answer. So what they will ask is difficult to predict in the exam. They may ask, let's say that T4, T3 is very high, TSH is low. So how will manage? Then you have to know how to manage a toxic thyroid. So anti-thyroid drugs, what drugs you will use, what are the problems, whether you will do a surgery in this patient, will be radioiodine therapy for a primary toxicosis. So everything you have to know because one thyroid can lead into different aspects of the thyroid. This is what other day Robin told with me that there are four aspects are there minimum in thyroid. It's probably malignancy, toxicity, multinodal goiter, solitary nodule, all those different concepts. So wherever you examiner can lead and ask exact questions or trouble you. Okay, so you need to know everything about thyroid when you present a thyroid. There is a reality actually because like Robin rightly told, it's a very vast subject. So lead to thyroidectomy complication, that is everything. So entire chapter you have to read. Clinical examination also you have to read properly, have a clear idea. And it's a very common entity we come across in day-to-day surgical practice, right, Robin?
Yes, sir. Yes,
So
sir.
that is the thing.
Yes.
And Lindsay has presented very well. Definitely full mark for her.
Thank you, sir.
That's distinction, I think, without any. She has answered most of the things, of course.
Thank you,
I
sir.
don't have answered when I was final year. She has answered very well everything.
Thank you. Thank you, sir.
Robin, just final remarks. Give a final remarks, Robin, to students. Then I'll just go through my slides afterwards. 5 minutes, my
Yes, sir.
5 minutes
Sir,
slide.
yeah, sir, I've been typing in YouTube all the major questions that they have to cover.
Okay.
So just the gist of it, history taking and clinical examination points we have already covered in YouTube. I've put it in order. Which are the
Okay.
tests that you have to mention? We have asked the main questions to Linsa also.
Okay.
How to investigate this patient. Now the treatment, like sir said, the differential diagnosis very important. Just to make it easy, how I teach the students here, you go for congenital anomalies, infective or inflammatory conditions, which is thyroiditis in the case of thyroid, obviously. Then you have benign conditions, you have physiological conditions. Yeah, you have hypo and hyperthyroidism. That's thyrotoxicosis and this thing. So we have to cover that also. You have goiters. There are three types of goiters which can be toxic or non-toxic. You start off with a colloid or diffuse simple goiter, which we call, which starts off with young age. Go to middle age, you have nodular goiters, again split into two. You have solitary or dominant types. Students have to know the difference, the definition they will ask you in the exam between solitary and dominant. Is a very subtle difference. And the investigation is also different for both because there is a clinical inference to it. Solitary and dominant malignancy role is very important, so you should know. Then we will go to multinodular goiter. Here, the question the examiners will ask is what are the stages? How does it go from colloid to nodular to MNG? Please read SRB sir's textbook. There's a small table he has put from the second edition onwards. I've been reading it. It's just by hearted. It's more than enough because he has explained how TSH fluctuates and causes this colloid to nodular to MNG. It's very interesting, very easy to read. Once that is done, then you the only thing left is benign and malignant. Benign neoplasm. You have adenomas. You have papillary adenoma and follicular adenomas. You have carcinomas. You should know the classification of thyroid neoplasm. There's a name for that classification in the latest books also. You should know it for well differentiated and the other type. Now, in that, they have usually put it as the old books have follicular and non-follicular, like as in testicular carcinoma, seminoma, non-seminomatous. You should know what is the name. That's a Dunhill classification. You should know. So this is the differential diagnosis. Investigation to make it easy again for any case that comes to you in the OP. Triple assessment, thyroid function test. You have imaging. With this itself, you have a basic idea of what we are dealing with, a benign or a malignant problem. Nowadays, we have duplex scanning also with ultrasound, so it will give you a clue if you're dealing with a malignant problem. Three, you have FNAC. That gold standard for NEET exam is, I think Sir will reiterate, is ultrasound guided FNAC.
Quadruple assessment now. Thyroid quadruple assessment. Like that.
Quadruple assessment. Because the other thing is triple assessment for breast examination. Okay, so there is no biopsy involved. Now, there's just a question that you can refer because we don't have time. Indications for FNAC other than that is we will not only miss follicular carcinoma, you will miss follicular adenoma also most of the time. And there are two more conditions. Four conditions you will not get in FNAC in this thing. You should know that also. So once that assessment is over, you know what you're dealing with, you go to the treatment modalities. Okay, benign problems, you know what to do. Treatment thyroidectomies. What are the different types of thyroidectomies? You should know subtotal, we don't have partial anymore, subtotal, total or near total. So difference between sub and near total, it's in the gram. So you should know that. Sir has already mentioned a very fine point, I hope you've heard it. We want to avoid hypothyroidism, and we want to also know carcinoma. So that is why in some books you see it is the surgery for papillary carcinoma is total or
Yes.
near total. Near total. So you should know the difference as to why they have written it. So and you should know how many gram. Less than 2 gram, and the other one is 2 to 4 gram or 4 to 6 gram subtotal. Okay, that hypothyroidism is why the Western literature also they don't do a total thyroidectomy most of the time. Next is neck dissection. Types of neck dissection when it comes to thyroid swellings. Central, which is the most common, which you already know the group of lymph nodes. Then you go for the functional neck dissection or the lateral. Just a point here. What is the lymphatic pathway of thyroid cancers? It is there in his book. Please refer it, or we will try to put it in YouTube. The lymphatic pathway. There are two pathways: the ascending pathway, descending pathway. You have upper and below. This is just a gist of it. So this is the basic management and the whole thing of a thyroid swelling. I think sir will just
I'll just
revise his slides. One is ready. Yeah, Lindsay has presented well.
for
Sir, just a fun fact. She was our first prize in quiz for our CME, which you had come to, sir, in
okay, very
Tirunelveli.
nice, very nice. Congratulations, very nice, Lisa.
Yes, the same questions for postgraduates. Our undergraduate scored first. She is the first one.
That's
Yeah.
good. Congrats. So just go through the slides for student purpose.
Yes, sir.
Robin. So next slide. So history, all those things you were asked. So olden days they will talk Derbyshire neck, Himalayan goiter, the goiter belts. In theory, they may ask, or in clinical presentation they will ask. So mainly why butterfly shape it is. Now why it is important to see this male thyroid consideration always a high risk group. That's a point you have to remember. Any male thyroid swelling in the male is not that common, but when it appears, you have to always consider malignancy unless proved otherwise. Male thyroid in male patient is always a high risk category, so needs always surgery. That's why I put male thyroid here. Next slide. So thyroid is the only endocrine gland which is properly accessible clinically, only gland that can be involved in all age groups, only gland where malignant tumors are mostly non-functioning, remember, unlike other areas. So these are the things in the chief complaint you have to always all highlight so that you will have the functional status, local extension, and pain and duration or complications, okay? Chief complaint. Next slide. So I just put the history in the table for swelling, pain, fever, pressure symptoms toxicity, symptoms hypothyroidism, positive swelling. All other things are for management purpose. Treatment, surgery, drug intake, thyroxine, and there are others. Others are goitrogenic drugs, which already you have already discussed. Family history, family tree is important, which already told why it is so. All those things. And menstrual history also again it's very important because thyroid will show some fluctuation in toxicity, hypothyroidism. So this is a history chart. Next slide. So general exam again, eye signs are important. There are sometimes some examiner accept you to present eye signs in the after the local examination, but you can always present in the general exam. You can say that it's here. If the exam says present it later, we can always switch over to your the eye signs into the later period. It's only 4 5 signs which you have discussed. Whatever you have present are important. Don't require to remember all 20 signs. In case they ask, we can blindly tell that sir, I can't remember. I have read it. I can't recollect it. Please. We can always tell that it's not impossible to remember 20 25 signs. What is crucial, whatever you have discussed, the 4 5 signs are very important. That point, that signs you have to remember. Other the sleeping pulse rate, trials, bleeding, we have discussed. All these signs are important, which you already discussed. Next slide. Next slide. So this is in the chart I have put swelling, inflection, movement in the deglutition. That is very very important. Then pressure effects, Pizillo's method I have discussed. There's a W2 grading 0, 1, 2. There's still modifications are there. There's a basic thing you have to sometimes you'll ask. Trials method of palpation, Pizillo's, Cocker test, Pemberton sign, trail sign, trachea, little trachea, lower margin, Leahy's method of examination, fluctuation, fluctuation, and trill in the upper pole. Plain of the swelling by checking the sternocleidomastoid muscle. Already Robin has discussed that one, fixed T fungation and carotid pulsation. All these are the things which are very important while examining. Which already we have discussed. I have put in the table form so that students all, if you remember this table, will be able to express it clearly. So movement of the is very very important to say it is why it is thyroid. Once you say the final diagnosis, they will always ask why is it thyroid. First thing is sir, it moves with the duration. So why it moves with the duration, you should be able to answer. That's a point very important. All of these tests how to do it, you should remember it will be asked. So plain of swelling is contraction of sternocleidomastoid muscle. Other things are mainly academic. Next thing, next slide. So other examination again, oral cavity scalp, you have to already why it is you have discussed percussion, auscultation, And like the lymph nodes are important, they should come first, of course. And systemic examination, again, respiratory, abdomen, cardiac, and all this come. Ankle jerk, you already told, knee jerk, ankle jerk, and hyper and hypo. Skull spine, skull is mainly for METs because pulsatile swellings are very common localized in follicular carcinoma of the thyroid. Next thing, so diagnosis, you have to always put it like that: multinodal goiter, non-toxic, toxic. Right side, which side is important? Nodule. If it is both lobes, both lobe, one side, one lobe, whether it is possible to have carcinoma of thyroid, solitary nodule, like that. Specification, you have to, how will manage? When you say somebody says how will manage, always immediately say, sir, I will do thyroidectomy. It is not so. Evaluation and treatment. There are two parts in the management. Any long case, any case presentation, how will manage? Always tell evaluation. I will evaluate first, then tell the treatment, not straight away treatment. So that's evaluation, treatment, management content, evaluation, treatment. Next thing, next slide. So these are the differences. Movement to the declaration, give water actually, lower border, butterfly shaped, trials method. This is the sternocleidomastoid muscle contraction, like I've been told is the term. Next slide. Next slide. So the, this is the how exactly examine from behind. Then again, Kyle's method, trachea palpation. See that deviation of the trachea towards the three-finger test like this. Next slide. So toxic thyroid, pre-tibal myxedema, pedal edema, two things. Already Robin has discussed properly. Eye sign, the starry look at that. With the Leahy's method of examination. With the Navzeiger's method, this is important. Navzeiger, I don't know whether you have put it or not. Navzeiger to see whether it is like this. From behind to check for the protrusion of the eyeball. And this is the Mobius sign. This is the Van Grief sign. This is the Geoffroy sign. So Geoffroy's, Mobius, Van Grief sign, and carotid pulsation here. This is a Nabziger sign. This is a Leibniz method. Pre-tibial myxedema here. Toxic thyroid. See that thyroid with the starry look. Okay. Right. Next slide. So again, same thing. Solitary nodule is there. One large nodule. Male patient could be malignant. It's a multinodal goiter here. Toxic thyroid. It's a colloid goiter. How it looks like that. Next slide. So it's a malignancy which is fungating here. Again, male thyroid with the malignancy, it is almost involved in the sternocleidomastoid muscle. Again, fungating follicular carcinoma thyroid. The typical lingual thyroid, the oral cavity you have to examine. See that posterior middle third, posterior of the tongue midline. Typical lingual thyroid. The short note for you, lingual thyroid. Or neck you have to examine. Empty neck is important. Next thing. Next slide. So yeah. So remember this thing: functional status, compression, neck lymph node, trachea, carotid, features of malignancy, retrostal extension, different systems. Trials method, trials grading is different. For sleeping pulse rate, P3, serum calcium level you have to do. You have forgotten this. Ultrasound neck, FNAC, indirect laryngoscopy you have discussed. Thyroid autoantibodies, radioactive iodine therapy. The technician study for only study purpose can do. MRI, CT scan, that controversy I have told both are acceptable. MRI, some people expect you to have tell MRI neck. Serum thyroglobulin, we have discussed that. Remember again these things: what is thyroid steel, thyroid paradox, lateral aberrant thyroid is a misnomer. Different tests you have to remember, different eye signs, cause for rapid increase in thyroid, anatomy of thyroid lymph nodes. Already he has told that ascending different lymphatics, primary, secondary. Robin has discussed in detail. Parathyroid gland, 4 is above, 3 is below. Remember, parathyroid glands, recurrent or berries, ligament berries sign. Since already discussed, lingual that has shown pre-tibial myxedema, exothermus, causes of goiter classification, Dunnell classification for malignancy as discussed, other classification for goiter you have to remember. Next slide. So this is what exactly in brief. It's a very vast subject. 1.5 hours you have discussed. There's more than anything you cannot, the students may not understand. Please go through my book, clinical book, because the video lectures are there for how to examine. Theory also there. Everything is covered in my book actually. So you can always go through my website. My website daily small brief lectures are there. Links, I think you are going through that. And now I've added MCQs and quotation also in further. So MCQs I was busy in last 1 month. I'll start putting the answers from tomorrow onwards for all the lectures. Next slide. So this is my SRB Surgical Insight YouTube channel QR code. And my books, all of you know, clinical books, operative surgery and manual currently. So that is a briefly, Shreya, just a briefly about the thyroid examination. I think students have understood. Robin, you have discussed it
Yes,
very
sir.
well. Covered. I think we have covered most of the things. You have given the gist
Yes,
of
sir.
it at the end. So Lindsay has done very well. Actually, she has presented very well. Hope students
Thanks.
will be benefited by our 1.5 hours discussion
Yes, sir.
in an interactive session about the examination of the thyroid as such. Remaining thing, you can
Yes, sir.
always go through my book and other things and learn much more because very vast subject as such.
Yes, sir.
Robin. So shall we wind up, Robin? Linsa, you
Yes,
have
sir.
done very well.
Yes, sir.
Excellent. I'm
Thanks.
not just telling in front. It is actually you presented well, discussed well,
Thanks.
thought well. There are some every question you won't be able to, even I can't answer. It's a very vast subject. And Robin has discussed very well as usual. And I hope all students who have joined, because always somebody can go through this lecture and have a idea and get benefited for the how to examine a thyroid patient, which is always a long case and many short notes and long questions will be asked in the theory. Many MCQs will come in the thyroid topic actually. So with this, we'll conclude this one, and I thank everybody. Thank Robin very much for spending his spare time, probably his duty today, for 2 hours
Yes,
with
sir.
me. I really appreciate your interest uh, and your knowledge and discussion, interaction, and getting involved with the discussion. That's important. Lindsay has presented well. Thank you very much
Thanks.
for nice presentation. So with that, I hope students will be benefited with our lecture. It's a free access to everybody. Anytime they can go through this one and learn. So with that, thank you, Robin. Next week, my
Yes,
students
sir.
will present about the examination. Next swelling again, it's a very common short case kept in the exam. Next Wednesday, 7 to 8. I'll
Yes,
remind
sir.
you to join for the discussion. Important.
Definitely. Definitely, sir. I'll try to get in one of our colleagues from Kerala.
Yeah, please just
Because they had there many of the HODs have shown their interest to take part in the case
yeah, please,
presentations.
please, definitely because many of them I don't. Please communicate them, give them number. I'll
Yes, sir.
communicate. You communicate all.
Yes.
Communicate.
I'll
Clear
inform
minded,
Aditya
proactive,
also so that
because
we can.
everybody's knowledge is important. We also learn. We can
Yes,
make students to also learn. So next week also ask Linsa all if your batchmate to join this one for session.
Yes, sir. Sure.
Somebody else is our college students are presenting, but the discussion will be similar. We all have because
Yes.
it will be definitely benefited to all students. So please join
Yes.
the regular sessions of these. It will be beneficial to all students. So with that, we'll conclude and thank you very much and good day and good night and take care, Linsa, very well, Robin.
Thank you. Sir.
yes. Thank you
Shreya,
so much, sir.
Thank you, Shreya, Aditya,
Yes,
and
sir.
their teammate. They are doing excellent job. I'm just joining here with my clinical and of course subject knowledge. All other things, Sri Sriram is very perfect in their work. Aditya and Shreya and their whitelist team is excellent. There is no words to appreciate because these things are difficult for me to do. Everything, whatever time I say, they will always do the needed thing without any questioning. I really appreciate their help and uh, ability to do these things in a perfect way. So thank you everybody. Thank you for the team and everybody, Robin, presenter, students, everything. So we'll conclude with this.
Yes,
Join next week, Wednesday, 20th, 7 to 8 p.m. Thank you.
Yes.
Thank you,
yes.
Robin. Thank you. Good.
ലിൻസ
Thank you. Thank you.
ലിൻസ ലിൻസ പൊളിച്ചേ അടിപൊളി